So this is going to be the second time I'm doing this live, and last time we had a disastrous logistics with the whole streaming thing, but this time I've come prepared, I promise. Right, so just like last time, we're going to talk about some important topics first, and then we're going to come back and cover the cases. The first topic that I'm going to cover is the blood thinners. Of course, blood thinners. We're going to cover is the blood. Okay, sorry, that was just not totally ready with the logistics. The first topic that I'm going to cover is the blood thinners and hemophilia. In step one, you will often be asked about thinning of the blood and somebody who's constantly bleeding. The most common cause, of course, is VWF syndrome, which is factor VIII deficiency. This is the most common cause, even if the labs suggest otherwise. So the first thing that you should do if you suspect this of course, is to order the VWF levels. But even if the levels are low, there is still a quite high possibility that it is VWF. It is that common. If you really suspect and you want to rule it out, you have to do the ristocetin test, I think it's called. It's just a drug that they use to detect the VWF levels. So that's how we rule out VWF syndrome. The treatment for these patients is simply desmopressin. Desmopressin releases the intracellular VWF in our systems. So that's for the VWF and blood thinning. Okay. All right. The second topic that I want to cover is the Pap smear. Pap smear is, of course, very common in the clinical practice and also very common in the exam. And the exam you'll often get a long case, either asking you about what to do next, and the answer is, if it was a Pap smear, they will not ask you about whether or not to do Pap smear. They will ask you about the results of Pap smear and what to do next. So the first thing that you should do, of course, is if you suspect that a woman has malignancy in the cervix, then they should, of course, do the Pap smear. If Pap smear results were suspicious of malignancy, or you were yourself suggesting or suspicious of malignancy by your clinical judgment, then the next thing that you should do is colposcopy. So what colposcopy does is basically it looks at the cervix. Sometimes they spray an acidic whitish component that makes the malignant components or malignant cells light out and make them more visible. But other times they just look with the colposcopy scope. So for the colposcopy, you can look at the cervix, the whole thing. And if you see a malignant lesion that is small, then you can do something that we call conization. Conization, yeah. So they basically take a cone-shaped biopsy of the whole cervix on the whole area that is affected. And that's both diagnostic and therapeutic at the same time, because you're going to take out and excise the lesion, and you're going to send the sample to the labs for testing and to see which type of malignancy this is. So we do Pap smear. If the results are suspicious of malignancy, we do colposcopy. Colposcopy, if we see small lesions, that we can do conization and take them right away. If otherwise, you can, if you're suspecting that the lesion is too big, or if you do conization and then you take out the whole lesion, but there is still some lesion left at the margins that you cannot simply take out with conization, then you're going to have to go further and basically take samples of the remaining cells and send them to the lab. In most of these cases, if the tumor or the malignancy is that big that it left some small lesions here and there, then in this case, you're probably going to have to do hysterectomy. So, Pap smear, colposcopy. Of course, the most common cause for cervical cancer is HPV virus. HPV is very common and it is treatable. It's preventable more than it is really treatable, because you can prevent it with the vaccine. Okay. So that's for HPV. Okay, anemia with increased retics. I have some notes here that I keep looking at. So anemia with increased retics. If somebody gets a blood is having symptoms of anemia and we test it and we see increased retics, this is very significant, because retics are basically RBCs that are immature. So for our bone marrow to produce immature remaining cells, take a sample of them. Basically you should take a sample of the remaining cells if you feel that the colposcopy itself is not sufficient. Sometimes because large tumors, this is going back to the colposcopy thing. So if the tumor is very large and you feel that, because most of the time the tumor, if it was really big, the center of the tumor will be necrotic and they will die basically. So you're going to have to take a sample of the active cells at the margin of the tumor. Because the margin is normally the active area. Even with ulcers, the margin is the active area that you need to take a sample of. The center is not really that much diagnostic unless there's active cells, tumor cells in the middle. Okay, any other question about pap smears and colposcopy? Okay, moving on. So, anemia with high retic count. Reticulocytes are basically immature RBCs. And for our systems to have reticulocytes, this means that our body is actively trying to produce more and more RBCs, so much that it started producing defective or immature RBCs. So basically, it's a sign that tells you that the issue with the anemia is something outside the bone marrow that is destroying or taking away the RBCs faster than the body can replace them. So our bone marrow is trying to compensate by producing immature RBCs. So retics is very important and it's a very significant sign. So the fact that retics are high indicates sufficient bleeding material outside, okay? Yeah, another thing is that if the reticulocytes count is high, this indicates sufficient building material for the RBCs, which means our body have enough material to build RBCs that it's producing so much of them, and they're basically immature, so basically it indicates that there is an active bleeding elsewhere or an active source of destruction of RBCs outside the bone marrow. And the bone marrow itself is working fine because it is producing these retics. Okay, so retics is a sign of healthy bone marrow. So the cause is other bleeding hemolysis. Okay, we covered this. Okay. So yeah, these two psychiatric symptoms, disorders seem to be confused often together. The illness anxiety disorder and the somatic symptom disorder. It's very commonly tested and people get it wrong often. I got it wrong at some point. So basically, both of these conditions are patients who feel that they have a symptom or feel that they have a disease, and most of the time they don't, or they have a disease that is unrelated to what they're complaining of. So somatic symptom disorder refers to a patient who's having a symptom that he complains of, and he's very convinced that he has this symptom, although he doesn't. So the most common cases is abdominal pain. So if a patient says that they have abdominal pain and they keep coming to the clinic over and over again, and all the tests shows negative results, this is likely somatic symptom disorder. But the same thing can be said about illness anxiety disorder. However, illness anxiety disorder refers to the patient's preoccupation with the idea of being sick. The patient will not tell you that I have this very specific symptom of abdominal pain. The patient will say, I'm sick and I'm complaining of abdominal pain and this and this and that. So illness anxiety is more generalized, and the patient feels sick by the whole body feeling sick, or feeling that they have a certain disorder but they don't know what it is. In somatic symptom disorder, they have a very specific complaint, abdominal pain, and that's it. Or they have a very specific complaint of, I have numbness in my right hand, or I have dizziness when I walk at night, or something like that. So if the complaint is very specific, this is likely somatic symptom disorder. If it's generalized, this is likely illness anxiety disorder. Yeah, another also very common complaint other than abdominal pain for somatic symptom disorder is sexual dysfunction for males. So if you see other abdominal pain or sexual dysfunction, this leans more towards the somatic symptom disorder. If you guys have any questions, just feel free to stop me at any point, that's fine. Okay. So, bicuspid aortic valve. I think it was, I read an article. So basically, about 10% of the population are born with congenital bicuspid aortic valve in the heart. Of course, the aortic valve has 3 leaves or 3 leaflets. So if 2 of these leaflets are fused together, then the patient has only 2 leaflets. We call this bicuspid aortic valve. The aortic valve will be narrower, and the patient will sometimes have symptoms. Oftentimes, the patients are born with this. As I said, I think it was 10% the population that are born with this, but with time it opens. So, and normally patients who don't have the opening of the aortic valve and who are continuing living with a bicuspid aortic valve will complain of palpitation later on in life, and that's pretty much the only symptom that they're going to be complaining of. There are some studies that indicate anxiety related to bicuspid aortic valve and mitral valve prolapse. How are these connected to anxiety? I'm not really sure, but there are some connections there. So for these patients who are having symptoms of bicuspid aortic valve, normally we just don't do anything. We just give them beta blockers like propranolol. But if the symptoms are very severe enough, causing syncope or causing basically aortic stenosis symptoms, then you're going to have to do something surgical. But most of the time, just leave them be. You don't do anything. Medically, you can just give them beta blockers. surgery is probably the definitive treatment. Okay, so these are the topics that I want to cover. And now let's go to cases. Okay, so let's start with a very simple and, it's a fairly simple case. So it says a 44-year-old female was complaining of burning micturition and right flank pain. She was diagnosed with urinary tract infection and prescribed trimethoprim, which is a folate synthesis inhibitor. The symptoms persisted, and the patient developed stromal kidney stones. The patient took an additional antibiotic, which was amoxicillin. Her urinary symptoms subsided, but she developed new fever and diarrhea. Which of the following is used to treat the new condition? Metronidazole, azithromycin, aspirin, or vancomycin? Okay. So basically the patient had urinary tract infection. We gave her a folate synthesis inhibitor, which is the standard and the gold line, or the gold test that you go for. And then she developed new fever with diarrhea after giving another antibiotic, which was amoxicillin. And the question is asking about which medication we use to treat the new infection. This goes back to the same idea that says most of the cases in the USMLE are either 2 or 3-way questions. So this is a 3-way or 3-point question, basically asking you about something which is about something else. So it's asking you about the treatment of the disease that you should have known from this scenario. It's not asking you about the disease itself. And this is mostly the cases that you're going to see in the exam. They're going to ask you about something which relates to something else. Okay, so metronidazole, azithromycin, aspirin, and vancomycin. This is honestly fairly simple. The patient is likely to have pseudomembranous colitis, which is an infection caused by Clostridium difficile. So basically, in our guts, we have a Clostridium difficile cells just living there normally. That's their normal flora. And once the patient takes certain medications, especially amoxicillin and especially clindamycin, these two are the most common culprits to cause pseudomembranous colitis. These antibiotics are strong enough to kill most of the bacteria in the gut, but not strong enough to kill Clostridium difficile. So most of the bacteria will die. Clostridium difficile will be left without any competition for the nutrients in the gut. So the Clostridium difficile will thrive, and they will colonize the gut, and they will cause pseudomembranous colitis. And we have to treat this with another antibiotic. Previously, the gold line and the standard treatment was metronidazole. Recently, I think it was few months ago, maybe 3-4 months ago, it changed to vancomycin. If I remember this correctly, vancomycin or fidamoxicillin, antibiotic vancomycin. Yeah. Here's the guideline reads: vancomycin or fidamoxicillin should be used as initial treatment of even mild Clostridium difficile rather than metronidazole. The previous guidelines recommended the first line this as a first line therapy. So basically saying that you should start with vancomycin. Previously, we used to treat this with metronidazole, and this is a common target for exams because they like to ask about new guidelines and new things that are coming in the basically in the clinical practice. So, Clostridium difficile, pseudomembranous colitis, we treat it with vancomycin. If it doesn't work, we go for metronidazole. If it doesn't work, we go for fidaxomicin. Either one of these three. In the exam, you're likely going to see vancomycin and metronidazole, in which case you're going to choose vancomycin. Okay, any questions? Okay, so next case. This is a very interesting case. It says, multiple residents at a hotel experienced fever with productive cough. Some of them also experienced abdominal pain and diarrhea. The hotel recently hired a foreign company to install new equipment as part of the annual maintenance. The foreign company brought all the workers from overseas to install these equipments. How does the infection spread between the hotel residents? Does it spread from the foreign workers? Does it come from the foreign workers? Does it spread from one hotel resident to another? Does it spread from an infected water source? Or does it spread from fleas and insects? So basically, multiple people at this hotel are all experiencing the same symptoms of fever with cough, abdominal pain, and diarrhea. And they all started having the same symptoms at the same time, so there's definitely a source of infection. The clue given in the scenario is a foreign company that is brought from overseas that was recently also associated with the infection. And where does the infection come from? This is quite interesting because it's more microbiology with a lot of distractors. So, any idea? All right. So this is basically Legionella infection. Legionella spreads from water source, infected water sources. Yes, exactly, Legionella. Um, so basically, Legionella infection infects a main water source or air source, and then infects all the patients within that district, within that supplemental space. It does not go from one patient to another. And the big distractor thrown in there is the foreign company that came from overseas, and the same duration of maintenance is the same duration that they come with the infection. And this is a common distractor that you'll see in the exam. They'll give you 2 or 3 lines, sometimes even most of the question will be distractors, and the whole answer can be given in just 2 sentences, basically. Yeah, I should also stop bumping the desk last time, the footage was shaky. So yeah, Legionella infection infects the water source or the air source, and then it infects everyone who is supplied by the water or air source. Legionella infection does not transmit from one patient to another. So if somebody is infected, you simply give them the treatment and you send them home. There is no need for any isolation whatsoever. But you do need to treat the water source because it will continue to infect more and more patients. So I think that's pretty much it about Legionella. Yeah, that's pretty much it. You just need to clean the water source. There's no human-to-human transmission. Exposure is by, the disease is, you get it by direct exposure to the source. Yeah, right. So every disease in microbiology, and this is very interesting, because every disease in microbiology has a hallmark that tells you whether or not you should rule in or rule out this condition. Which is why when you look at the answers and you think that, oh, maybe this option is talking about Legionella, or this option is talking about Pseudomonas, every one of these options will have a hallmark that is definitely either ruled in or ruled out by the scenario. Legionella's hallmark is pneumonia with either GI symptoms or CNS symptoms. We only see this with Legionella. So if you see coughing, which is obviously a pneumonia and respiratory symptom, with diarrhea and abdominal pain, such as we see here, which is a GI symptom, this is a hallmark of Legionella. Or if you see, for example, coughing with difficulty breathing, and you see numbness, or you see somebody who's paralyzed, or you see confusion, this is likely also Legionella. So Legionella, it causes pneumonia symptoms plus either GI symptoms or CNS symptoms. This is the hallmark for Legionella. Okay, next case. Okay, so it says a college student came to the ER complaining of severe headache and confusion. His temperature was 40 or 39.9 degrees, which is 102.2 in Fahrenheit. Meningitis diagnosis was made, and the patient was given vancomycin and ceftriaxone. Soon after, the patient's entire body became red. His temperature is now 41 degrees, which is 105.8 in Fahrenheit. The treating physician immediately stopped the antibiotic infusion, but the patient's symptoms persisted. What is the best next step? So basically, the patient came in to the ER. The diagnosis of meningitis was made. He was given vancomycin and ceftriaxone. He became very red and very hot. And that's pretty much all the information that you have. So what is the best next step? Should you give the patient diphenhydramine and then reassure the patient? Should you check the GFR and hydrate the patient? Should you start IV ciprofloxacin, which is a fluoroquinolones? Or should you perform an MRI of the brain? Which one of those 4 do you think is the answer? So, this is an obvious case of red man syndrome. Vancomycin causes, no, it's not GFR. Vancomycin causes what we call a red man syndrome because the medication itself causes widespread release of histamine all throughout the body. And of course, histamine causes redness of the skin, it causes urticaria and all the rash symptoms in the skin. So widespread histamine throughout the whole body, and the whole body will become very red, and the patient will become very hot because histamine also causes hotness. So in this case, we should of course stop vancomycin, which the physician already did, and it's asking about the next step. The next step after you stop vancomycin is obviously to inhibit the action of histamine, so which is the first answer. We give the patient diphenhydramine, which is the first generation antihistamine, and we simply reassure the patient. Of course, the treating physician should start treating the patient with starting IV ciprofloxacin, which is the third option. But before you give the patient fluoroquinolones or ciprofloxacin, you should of course treat the symptom that he developed first, which is the red band syndrome. Another syndrome similar to colors and syndromes is gray baby syndrome. Do you know which antibiotic is associated with gray baby syndrome? So we have red band syndrome with vancomycin, gray baby syndrome with chloramphenicol. Chloramphenicol is a controversial antibiotic that we started, they actually discontinued recently. I think some places in third world countries, they still use chloramphenicol because it's very cheap and readily accessible. Yes, chloramphenicol. Chloramphenicol have very high risks and very high mortality rates, especially in infants, but it's readily used because everyone pretty much has it, and people still use it now, unfortunately. Basically causes dose-related aplastic anemia, so the patient will not produce. Basically causes bone marrow failure. That's all you need to know, because bone marrow failure that is associated with the dose. So the more you use, the more marrow failure you will have, and of course you need the bone marrow. So we don't like using chloramphenicol anymore. You're pretty much never going to see it as an answer to one of the options to which to use. You might see it in the exam, chloramphenicol. You might see as one of the legitimate options if it's asking about the side effects or the mechanism of action. But you pretty much will never see it as the treating option. Okay, so red band syndrome with vancomycin. Yes. There was a study that says whether or not we should give second generation antihistamines instead of first generation like ranitidine or cimetidine, but I think this study that I found recently says that the best treatment is diphenhydramine, the first generation. So yes, we're really slicing through these cases. All right, so it says a postgraduate student experienced severe headache and fever. He's an HIV positive patient, but non-adherent to his HIV medication. He has a history of multiple sexual partners in the recent history. In the ER, the patient lapsed into a coma. An MRI was performed and it showed multiple densities in both temporal lobes. He was given a medication which effectively resolved all his symptoms, and he regained consciousness. Which of the following must be monitored closely? Okay. So this is fairly straightforward. It's just asking you about, it's basically a one-way question, kind of, maybe a two-way question. It's saying that a HIV patient, he's maladherent to his medication, he has his recent history of multiple sexual partners, he lapsed into a coma, and MRI of the brain showed multiple densities in both temporal lobes. So there's definitely something wrong with the brain. And it's asking about which medication, and they gave him a medication that resolved all his symptoms and regained consciousness. Now, which should we monitor after giving this medication? It's asking you about a side effect of certain medication that you need to monitor. So some of you probably got that right away because some words there just give you the diagnosis, and you often see this in the exam. It's like 2 or 3 words that just link with something specific. And in this case, multiple densities in both temporal lobes. This is extremely characteristic of of herpes viruses, herpes simplex 2 or 1, mostly 2. So basically causes inflammation of both temporal lobes, and the patient will quickly develop confusion and coma, of course. If untreated, this can lead to death very quickly. And there is a syndrome that is often associated with the inflammation of both temporal lobes. I think it was called Clover-Bucy syndrome, something like that. Yeah, it's Clover-Bucy syndrome, B-U-C-Y, Bucy, I don't know how to spell that. So Clover-Bucy syndrome is basically if somebody had inflammation of both temporal lobes and they were not treated effectively, or sometimes even if they're treated, they will develop the Clover-Bucy syndrome. It's a complication of maltreatment of herpes encephalitis. So basically the patient will have increased appetite and they will have increased sexual drive. So they will be extremely sexually active and extremely hungry all the time. Why these two are related, I have honestly no idea. I think it has something to do with the limbic system, because while both limbic systems are affected, you will have this syndrome. So the patient has, we've established that this patient has herpes encephalitis, and we treat them, of course, with acyclovir, IV acyclovir. Now, which of the following should be monitored once we give the patient IV acyclovir? I'm not going to read the options because it's just honestly that obvious. IV acyclovir obviously causes renal failure, it causes renal damage. So you should monitor GFR. It just says liver enzyme, GFR, retina, the eyes, and cardiac enzymes, but you should monitor GFR with the use of acyclovir. Acyclovir basically forms small crystals that are needle-shaped crystals in both kidneys, and this will clog up the kidney and cause renal failure. So you should monitor GFR with the use of acyclovir. And because it causes the small crystals in both kidneys, we can simply dilute these crystals away by using a lot of water. So if somebody's taking acyclovir, you have to hydrate this patient very excessively. And if the patient is elderly or they cannot drink a lot of water, you should simply just hook them with an IV line, giving them normal saline. The more acyclovir you give, the more hydration there should be. Okay, so we have a HIV patient. We said HIV are naturally prone to herpes encephalitis. Herpes encephalitis is treated by acyclovir. Once you give acyclovir, remember to hydrate the patient. So these are all the cases that are prepared. 4 cases, I think. I can just do one more case, I think. I still have some time. Let me just open the case. Okay. It's a fairly simple orthopedic case, just a one-way question basically. So during a physical examination, the physician asked the patient to stand up and put her feet together. He then asked her to close her eyes and fold her arms together. Soon after, the patient started swinging from side to side and almost fell, but the physician caught her. What was the physician testing? So, in ideas, it says the options. The physician was testing the cerebellar function, or the fine motor function, or the vestibular sense, or proprioception. Okay. So, this is basically Romberg test. Romberg test, we use it to test the proprioception of the spinal cord. Exactly. So basically, your feet tells your brain at all times where their position is and how weight is distributed along your foot. So this is, for example, your foot. This is the ground, and this is your foot. Once you stand up or basically put all your weight on the ground. Both of your at all points of your feet are telling your brain at constant rate how weight is distributed, and this helps you to maintain balance. This is lost in things that basically damage the spinal cord, the posterior column of the spinal cord, or the brain cortex, but mainly the posterior column of the spinal cord. And this loss of proprioception causes the patient to swing once they don't have this input. So if a patient is standing still and they're having their eyes open and they can look around, they have another method of telling the brain where their location is, or how their body is distributing the weight. So they can look at the ground and say that, oh, maybe I need to just stand there. They can, most of the time they do this subconsciously. They can tell their brain that, okay, maybe I need to stand a little bit behind because my weight may be falling forward. But you don't need to do this if your proprioception was working fine. So if the patient, this test is called Romberg test. Romberg test tests proprioception. Fine motor function is mainly tested through the writing, tell the patient simply to write something or maybe sign a signature. And it's very obvious if a patient has a disrupted fine motor function, you'll see just swinging all over the place. Cerebellar function is tested by telling the patient to touch your finger and then touch their nose. They should be able to do this in quick succession, but if they can't do this, then there's a problem in the cerebellum. Okay. So how about one more case? Okay, this is a fairly simple case. So, okay. A leukemic patient received his first dose of chemotherapy. His WBC count drastically decreased from 53,000 to 13,000. However, the patient started feeling numbness, dizziness, and weakness. His lab findings are: the potassium level is 6.5, uric acid is 11.9, and calcium is 7.6. All of these are milligrams per deciliter. He was diagnosed with tumor lysis syndrome and treated with IV fluid and allopurinol. These kind of questions are really frustrating, but you will see them in the exam. I don't like I'm sort of like solving these questions because it basically says everything that you were thinking of when you were reading the question. As you read the question, you're probably thinking, oh, this is tumor lysis syndrome, tumor lysis syndrome. I want to just click on tumor lysis syndrome, but it says, oh, the patient was diagnosed with tumor lysis syndrome. And then you're thinking, okay, it's treated with this and that. And they says, okay, he was treated with IV fluid and allopurinol. And then you're going to be thinking, okay, what else do you want from me? And then it says, why did the patient develop hypocalcemia? His calcium level, as we remember, was 7.6 milligrams per deciliter. So the options are a side effect of the chemotherapy, chelation by cellular component, calcium consumption by cancer cells, calcium deposition in the GI tract. So which one of these do you think is the answer? So basically, tumor lysis syndrome, they have hypocalcemia. Why do they have hypocalcemia? That's the short version. Exactly. Chelation by cellular component. Our cells naturally, wait, I think I have it here somewhere. Okay, doesn't matter. So our cells naturally have a lot of potassium in them, and they have a lot of phosphate as well. Basically, there's a saying that says a cell is a banana in the sea, because a banana has a lot of potassium and the sea has a lot of salt, which is sodium chloride, sodium. So a banana in the sea, a lot of potassium, and the outside is a lot of sodium. So the cell has a lot of potassium inside, and it also has a lot of phosphate. And once the patient's cell count, the leukemic patient cell count decreased from 53,000 to 13,000. So there's about 40,000 cancer cells that have just died in the span of one session, in the span of very short time. So all of these cells will release their inner components into the bloodstream. And the patient will have increasingly very high levels of potassium, as we see here. It's 6.5. Of course, the normal is from 3.5 to 5. And they will have, of course, a lot of uric acid. But this is interesting. Why do you think they have increased uric acid while the cells themselves don't have any uric acid in them? Why is there increased uric acid with tumor lysis syndrome? So, uric acid, the cells also, as we said, they have a lot of basically cellular components, but they also have a lot of proteins. And once all these proteins are released into the bloodstream, they will be broken down into uric acid, and that's why they have a lot of uric acid. And they will also have uric acid stones. Matter of fact, there are very few situations that we can see uric acid stones in them. I think this is the only one. This is one of the few ones that you can see uric acid stones in the kidneys. So they will have the patient has 11.9 milligrams per deciliter. A lot of uric acid. Uric acid comes from the proteins that is broken down after the proteins are released into the bloodstream. So, yeah, like we said, potassium, uric acid, and phosphate. These are the released into the bloodstream, along with some other components. Phosphate is very interesting because phosphate will chelate calcium and it will cause decrease in calcium, not increase. So the patient will have increase in pretty much all components, and the only thing that will decrease is calcium. Okay. Of course, it tells you the treatment right away. If you suspect a patient to have tumor lysis syndrome, you should give them IV fluids and allopurinol. Thank you. I think we talked about this case before in some video, but let's have it anyway. So, an office worker came to the ER complaining of severe headache and fever. CSF analysis confirmed meningococcal meningitis, and the patient was given appropriate therapy. His colleagues who work with him in the same office are worried about getting infected, given that all his colleagues came in contact with the patient the day of his symptoms. Which of the following colleagues must be given prophylaxis for meningococcal meningitis? So it's basically saying somebody who works in an office in a closed area space, so they definitely came in contact with everyone in the office, and this person was diagnosed today with meningococcal meningitis. He came to the ER with fever and they diagnosed with meningococcal meningitis. Who else in the office should be vaccinated or should be given prophylaxis against meningococcal meningitis? Should we give the prophylaxis for everyone who is not vaccinated against meningococcal meningitis? Or should we give it to everyone regardless of their vaccination status? Or should we give it to anyone who stayed in close contact with the patient for at least 1 hour? Or should we give it to everyone in the patient's building, the whole building, regardless of contact, regardless of whether or not they came in contact with the patient? Okay. All right. So basically, if a patient has been confirmed meningococcal meningitis case, you should give the vaccine or the prophylactic treatment. It's the second one. For everyone who came in contact with the patient 7 days prior to developing the symptoms, the day of developing the symptoms and taking the treatment, and then 24 hours after taking the treatment. So, for example, if the patient was given the treatment today we diagnosed him with meningococcal meningitis and we're giving him the treatment. 7 days prior to the treatment, everyone who came in contact with the patient should be given prophylaxis as well. And 24 hours or 1 day after taking the treatment, anyone who came in contact should also get the treatment. And this is regardless of their vaccination status. Meningococcal meningitis is very serious and very severe. So we don't take any risks. Even if you're vaccinated, you will also get the prophylactic treatment. Most of the time, they're just taking rifampicin for, I think, 7 days or 10 days, and that's pretty much it. That's all you need to take. So it's a very common, it's a very serious disease. So you take the prophylaxis 7 days prior to the disease, prior to treatment, and 1 day after treatment. That's the duration that you should basically you should vaccinate everyone in this duration. All right, I think I'll end it here. Is there any other topics that you want me to discuss or any other questions about anything that we discussed or anything at all? All right, so I think I'll end it here and I'll see you guys later.